A problem with your hand? You may have Dupuytren's contracture. Welcome to Talking with Docs. I'm Dr. Paul Zalza.
I'm Dr. Brad Weening, and today we have a guest, Dr. Noor Al-Labi.
Hi, thanks so much for having me on your channel. Really appreciate it. You guys have been doing some great stuff.
Oh, thanks for being here. So yeah, we're talking about Dupuytren's contracture.
Yeah.
And stick around. I have some medical history.
Usually you do.
About why we call it that. But tell us what it is.
Yeah, so Dupuytren's contracture, essentially it's a mainly genetic hereditary disease actually. It's fairly common, we see it lots. It's very common amongst the Northern European backgrounds, Scottish, Irish, Scandinavian, English, etc. And essentially what happens is you develop sort of fascia that's thickened. So we have this layer underneath our skin in our palms and our fingers called the fascia. And what happens with Dupuytren's is the collagen ratio changes.
Okay, so basically it's a condition where you can't put your hand out flat anymore.
That's right.
You can't put it flat on a table, your fingers start to bend and kind of stay that way, and you just can't straighten it no matter how hard you try.
Yeah, it's a painless disease, so that's not really the complaint that people come in with. So they go to their family doctor, they notice a lump in their palm, and they're wondering kind of what this is. It's mainly actually a physical examination disease that you can just diagnose with physical exam. So you don't need any tests, you don't need an ultrasound, you don't need an MRI, you don't need an X-ray.
Wow, that is a cool condition because almost everything we talk about has some kind of investigation associated with it. So this is the history of just having some bumps and then eventual contractures of your finger, and then it's diagnosed on physical examination by your physician.
That's right.
And so a little more about who gets it. So more commonly in men than women, is that correct?
Correct. So it's about a 7-to-1 ratio actually.
Okay.
It's usually in sort of older ages, we're talking starting 50s, 60s. If you get it in your 30s, usually it's a more severe disease.
Makes sense.
Typically, when we see it in people in their 30s, they may actually have it involving their hand. They can even involve it in the feet, as well as in male in the penis.
Okay. And so in that group of people, I read a little bit about the risk factors. So what are your thoughts and your experience in your practice with things like drinking, smoking, diabetes, rheumatoid arthritis, that kind of stuff?
Yeah, so I mean, if you read some of the articles online, a lot of these are outdated. So you'll read a lot about some risk factors.
Right.
Honestly, at the end of the day, it's mainly genetic. So that's the biggest thing.
It's not your fault.
So alcohol intake is not a risk factor anymore, considered?
It's really, we don't consider it.
Paul's looking for an endorsement.
I'm just saying, because I remember as a medical student,
That's right.
alcohol intake was one of the risk factors.
Whether liver cirrhosis, so because of drinking and then causing liver disease causes it, I'm not so sure that's the case.
I committed to memory because I thought, oh well, if someone who's drinking a lot falls asleep with the glass in their hand.
That's not the case.
No, but that's how I tried to remember that risk factor.
Okay, so you go to your family doctor, you have a contracture, your doctor confirms, yeah, we're highly suspicious that you have Dupuytren's contracture. Right. Where do they send you? Do they send you immediately to a plastic surgeon like yourself?
So sometimes, honestly, we do see people getting X-rays, ultrasounds, MRIs, but really that's not necessary.
Okay.
But the step after that usually is going to a plastic surgeon or a hand surgeon. So in the States, orthopedic surgeons will do hand surgery. So sometimes they'll go to ortho, sometimes they'll go to plastics.
Okay.
We see the patient, and essentially we do something very simple. We say, let's do the tabletop test. So you put your hand flat.
Yeah.
Does it actually go flat, or do you have a bend? And if it is flat, we honestly don't need to do anything.
Okay.
So again, these nodules aren't painful. So if they're just present in the palm or in the finger and they're not causing a contracture, so a bend, the reason you get it is once it crosses a joint, then it's going to start to bend that joint. So if that's not present, we don't have to do anything.
You wonder if Spider-Man had that disease?
I think after a while,
right?
Why, was he a drinker?
No, he was just holding us for a figure. So it's really a functional assessment, right? So
it's a functional.
And if the patient said, well, listen, even though my finger's like this, I can live with it. You don't have to do anything. You're not obligated to have any treatment.
Correct. The only thing that we worry about, though, is we don't want to leave this too late.
Okay.
So what happens is if we develop a contracture and it's present for a long time, those joints then become used to the position they're in. And so it becomes more difficult for us to treat it and reverse that contraction.
Okay. And obviously there's a functional implication to not being able to straighten out all your fingers in terms of grappling things if you're working with your hands.
Exactly.
Like
I mean, some of the complaints is, well, I can't put my hand in pocket, I can't shake someone's hand. Those are the common things that we hear about.
Okay. All right. So how is it treated?
Yeah, so there's really 3 ways to treat Dupuytren's. The first one is something called percutaneous needle aponeurotomy. It's a big mouthful, but essentially what it is something that can be done in a clinic. We freeze up the palm or the finger, wherever the cord is. And then we take a needle and we literally just kind of scrape that cord slowly, and we try to essentially cut that cord.
Shave it down.
So essentially what you're doing is, if you've got a contracture like this, you're splitting that cord, and then slowly you can open that finger up. So the idea is not to get rid of the disease in this case, but all we're doing is we're splitting it. Think about it as a rope, and you're splitting that rope in a couple of spots, so it's no longer pulling.
And for the patients to understand, you're not splitting the tendon.
No.
This is the cord that's on top of the tendon. So you're being careful the depth that you go.
Absolutely.
Right.
So that's actually a very common misconception, is people think that it's the tendon
Right.
that's actually bending the finger. That's not the case. It is, again, it's the layer above the tendon
Right.
that we're trying to split here. And you're absolutely right. So, sometimes it's very tempting. You see this thing in your palm and you just want to take a knife and split it. Please don't do that.
Yeah.
So, there's a lot of important stuff, nerves, tendons, etc. We know where we're going with this.
So with the needle, so 10, 15, 20 minutes in an outpatient clinic.
Yeah,
You're going home the
sometimes
same
even shorter.
day.
Yeah.
And then what would the post-op protocol look like for that patient?
Yeah, so literally this is something that, essentially think about it as you're taking blood, where you have a little needle poke. Essentially it's like that. Okay. So there's really not much recovery. A couple of days you may feel a little bit of soreness in the palm, but that's really about it. Patients come in, we do this procedure, it takes 5-10 minutes.
And you instantly can obviously see the benefit, right?
Right away.
So it's in
And you're
live.
not splinting it after for a period
We're
of
not
time.
splinting
gonna ask that
it.
same
If they have a contracture, then obviously splinting would be helpful.
Okay.
However, in these cases, usually we're opening up a lot of this is done in the palm as well.
Right.
For this type of treatment. We can do it in the fingers. The only thing in the fingers is that the nerves are closer to the cords.
Right.
Sometimes there's these cords called spiral cords, and so the nerve actually goes and literally spirals around the cord.
Well, that's unfortunate.
Yeah, so we try to not, we really got to be careful there.
Yeah,
So we try
okay.
to just freeze literally the skin just
Okay.
on top of the cord, and slowly ask the patient, can you feel anything? Can you feel anything?
Right.
You know,
Okay.
so.
And presumably the needle treatment is for earlier disease rather than more severe stuff, would you say?
Yes. So I think, one element is that once you develop a joint contracture, there's, again, almost like a memory factor in there, where the joint is just going to be quite tight, and you have to you may even need to release the actual sort of the joint capsule.
Which can't be done with the needle.
Which cannot be done with the needle, exactly.
Okay, so needle, number one. What's option number two?
Number two is no longer available in Canada, unfortunately. So that's Xiaflex or collagenase. So that is basically an injection. It's an enzyme. You inject it, and essentially it breaks down the stuff, which is the collagen that's in the cord.
Okay.
It's a private, essentially treatment paid privately, and that's why it pulled out of Canada. So we don't have it, but it is still available in the United States. So for those,
So essentially, it's a company that makes this enzyme. You inject the enzyme, breaks down the collagen, and we don't do it because there's not the demand for it.
Correct. So
Okay.
it's out of pocket or insurance
Right, so
coverage.
it's expensive.
So in a Canadian system where it's a public system, it was
Successful?
successful. Yes,
Okay.
yes, can be successful in the right patient.
Okay.
So again, you have to have a very identifiable cord, one that's close to the skin,
Yep.
and then one that is causing a contraction.
And
same
again,
kind of procedure.
earlier disease.
Yes, to some degree, yes. Also early disease, yes.
Okay. So then we're going to, for everybody else, collagenase is definitely an option for you depending on where you live. Same success rates or slightly better than the needle?
Collagenase and the needle are comparable.
Okay.
There's certainly some new studies out there that are trying to compare collagenase to needle to surgery.
Yep.
I think just for simplicity, it's comparable to the needle.
Okay, so I think number three is going to be surgery, but before we get there,
That's right.
is there any role for things like cortisone injections? Because I think historically that was done quite a bit.
Yeah, so I would say the most common scenario that we use cortisone in is sometimes when the disease first starts to develop.
Yep.
It can be a bit uncomfortable and painful.
Okay.
And sometimes people used to inject steroid to sort of get rid of that pain.
Okay.
But it
that's
didn't help with the disease progression.
There's again sort of a theoretical thought that, hey, if you inject cortisone, it might sort of halt the growth of the disease. I'm not sure that that's proven so much, but certainly it's not within our treatment algorithm.
Okay, not one of the big three.
Not one of the big three. Absolutely not.
Let's go to number three then.
Yeah. So number three is surgery, as you probably guessed it. So in the first two, you're not really getting rid of the disease. All you're doing is you're splitting the cord, in a way where now you've got a straighter finger.
Yeah.
The third option, the surgery, we are actually cutting out the disease.
Okay.
All right, so it's a day surgery procedure, depending on how many fingers are involved. So again, usually the ring and the small are more involved in this disease, but we can certainly see it in the other digits as well. So we can go in and we essentially open up the skin, examine that whole cord, cut it fully out to decrease the chance of recurrence.
Local anesthetic and sedation.
Sometimes we put the patients to sleep.
Okay.
Sometimes we can do it under local anesthetic and sedation, just depending on how involved it is, how long we think the case is going to be, but certainly doable. We can do it under a sort of what we call a local or a regional block, so your arm is fully frozen as well. We can certainly do that.
So recurrence rates, that presumably has the lowest recurrence rate.
Correct.
What would be the recurrence rate for like options 1 and 2?
Yeah, so certainly for the options 1 and 2, you're looking sort of within 5 years, somewhere around 30% or so. I'd have to probably just really brush up on my literature here, but somewhere around there.
Sure.
As for the surgery, it is lower than that. The one thing with Dupuytren's is we really cannot predict in which patients is it going to grow very quickly versus how long it's going to how long it's going to take to grow that quickly. We really can't predict that. And so again, we see this in some patients where in months they've got this cord and it's gone much worse, whereas in others it takes years for it to grow. So we certainly see that.
Okay.
So question, regardless of the treatment,
Yeah.
after I get a straight finger, is there anything I can do to prevent recurrence or not really?
Right. So actually, very good question. A lot of people will ask us that. And they'll ask us that even before
Sure, can I do
surgery.
physiotherapy?
That's
Can I
right.
wear a splint? Can I?
So we really don't think that pre-operative splinting or stretching is really going to do much. The disease is just stronger than what we're going to do to it. However, post-operatively, a lot of us will still splint patients. A new study actually showed that there's perhaps not any
Benefit?
change and benefits to it.
Just kind of made
I
sense
think
intuitively,
it makes
but-
sense, but it's not for the disease so much. We're doing that for the joint. So
Okay.
again, I think the MCP joints, so these joints right here, those are very forgiving. So if you've had Dupuytren's for a long time, just bending that joint, this will correct itself after surgery, or again, needling or Xiaflex. However, when the PIP joints, so the middle joints right here, when these are involved, these are notorious for them just to stay and, they have a
very
good
stiff.
memory. They're stiff. They just want to go back to where they are. And so a lot of times we do actually need to release some of the capsule of the joint, basically the structure of the joint, to sort of open it up.
These must be the knees of the hand.
Basically.
The knees are the
Yeah,
same.
we don't like those joints.
All right, so this was described by
Okay.
Baron Guillaume Dupuytren
Okay.
in
Yeah.
France in 1831.
Okay.
He knows the history.
Yeah,
He
So
knows
we
the
should be
history.
talking about la contracture de Dupuytren.
Okay.
To put it in historical perspective, that's 10 years after Napoleon died.
See?
So they might have met.
So what happens? Paul goes to France
Good
for
friend,
summer
good friend.
vacation,
was
and
great.
then that's it. He just learns everything about France.
No, but on the way home, I watched Napoleon on the plane. Most of it. It's a long movie.
I still haven't watched it.
Did you haven't seen Napoleon?
No, not yet.
Really?
I want to.
Watch Napoleon. Tell me what you like better, Napoleon or Napoleon Dynamite? I
Yeah.
prefer Napoleon Dynamite.
Back to the dynamite.
Your quote.
What's that?
Your quote.
Which? What
For
Tina
Napoleon
gets in hand?
Dynamite.
Eat the food. Eat the food.
No. Broke my coccyx.
Oh yeah.
I love that.
It's a great one.
So they might have even gone to the cafe together, shared a croissant, Napoleon and Dupuytren.
You very much good. Very much good.
Now you know everything you need to know, maybe more than you wanted to know about Dupuytren's contracture. If you have had experience with this or know someone, please leave a comment, share it, helps other people. If you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health. If you see these nodules in your hand, get to the doctor quick, because as you've learned, the earlier treatments are a lot easier than the more advanced treatments.
And thanks to Dr. Al Live for joining us today.
Oh, my pleasure. Thank
see you next time.
Thank you.